is a perfect case for a carotid indication. So as it was mentioned previously, 60-year-old female with acute or subacute stroke 10 days or 2 weeks ago, without morphological change, brain changes on CT. So it means clear indication of carotid revascularization. So we will do this procedure by distal protection with EmboShield NAV6 filter. We can discuss during the procedure later on about other opportunities for protection. And because there is, in some projection, there was some visible thrombus in the ostium of right internal carotid artery, we will do this procedure without predilation and try to do it as quick and as smooth as possible.
So I will run the angiogram so you can have a look. Can we have the first angiogram? Okay, can you see the fluoro? Okay, so we'll just show them. Show the first one, first angio. Okay, so we have gone from the left common femoral artery. This is a diagnostic right coronary artery catheter to do an angiogram, and then we have gone up to the left right common carotid artery. Next. And after that, what we do is we advance this catheter with the help of a wire into the external carotid artery, and then change the soft thermo wire with an implant superstiff wire, which is parked into the external carotid artery. And then on this, we take out the sheath and put a shuttle sheath, which has a dilator inside, advance the sheath to the common carotid artery, and then take out the dilator and the wire, and then we are all set to work on the right internal carotid artery.
So we can go with live now. We are.
So now we are going live, and this is the NAV6 protection system.
So the yes.
Yeah, you can get in.
The importance of this system, it is independent wire and filter. So particularly in this situation, you can see the advantage of such a system, because the risk of distal embolization and negotiation of very complex anatomy is much smoother. So I'm advancing now system, and at this stage it's very important to decide about the landing zone. So in this situation we are pretty much fine here, okay, and we will open our filter.
Opening the filter is very simple. We just have to sort of desheath this filter.
And during this procedure, it is very important to have all of your material ready on a table, because you do not have to wait too much with the deployed filter. And we'll go with the exact.
So now, when the filter is in place, we'll just give a short angio and show you where the filter is. Mag, yeah. So this is a magnified view. Now we have a exact stent. Where is the stent? And this is 8 into 6, 8 tapering to 6. This is a closed cell design, and this is 40 millimeter in length. So if you use a tapered stent, the advantage is that it will produce less of bradycardia and hypotension. And because it's a closed cell design and we thought there is a thrombus, it is a perfect stent to actually trap that thrombus and material there.
So at this stage, it's also very important to do de-airing at this stage.
One second.
It's coming.
Yeah.
We need some patience to take time for relieving the whole system with the air, because during the advancement of a stent, always we are introducing making some Venturi effect. And of course, it's very important to have as short as possible filter time. We try always to do in a single digit, between 4 and 9 minutes of filter time.
Yeah, you're closed?
Yes,
I
no,
think
you
this
have
one.
some air.
Yeah, because it's open here.
No,
Please
now
close it.
I'm opening, yes.
Closed?
Yes.
Let me
now
aspirate.
Aspirate a little bit. Okay, just
No,
okay.
there is a lot of air.
Allow it just to the air.
इसको निकाल दीजिए.
What do you think about the indication of carotid stenting in this particular situation?
Lower lock. Wait.
Yes, yes.
Let me fill up with
No,
air.
no, just a little bit from here, just to the air.
Can we increase the volume? Volume. Closed?
Yes. For what? For I did not catch your point.
How much do we wait after stroke for stroke?
So it depends. Sometimes, if there are no morphological changes on CT and patient is symptomatic, we try to do it as soon as possible. But if there is some structural brain damage with penumbra on a CT perfusion, then if it is a well-defined infarction, then we do not have to do it quickly. We have to follow the patient and decide later on.
You have to tighten this. There's some air coming in.
Yes, in 2 weeks we do control CT. We do control CT, and if there are no changes, then we proceed with revascularization.
Wait. Yeah, we'll change this. There's some problem here. You can directly inject.
Just directly, just a tiny injection.
This
Yes,
is
it's close. Just a bit.
okay. Here on floor.
Yes, yes.
One more.
A table. No, it's fine. A view.
Pull the pill. Okay.
No, view. Repeat view, please. Repeat. Say fluoro.
I think we'll take a scene.
No, let me just see the. No.
Niche
Table,
दिखाओ.
please.
Okay. Take a scene.
Okay. I will pull back.
Yeah. Sister, इसमें डाई और ले लीजिए. So we are just
Now we are deploying the stent.
It's very simple to deploy. You have a sort of a screw-like mechanism. You unscrew
520.
and the stent just opens. So this is without pre-dilatation. Normally we do without pre-dilatation as far as possible, but here because there was a thrombus, we were very clear that we don't have to pre-dilate. And post-stenting, we are doing a dilatation with a 5 millimeter balloon and just at nominal pressure, because you need to understand the rationale of doing carotid stenting is not to reperfuse the brain, but it is to prevent distal embolization and to trap the thrombus. It's open here.
No, it's at this stage we allow some back bleeding in order to have a safe removal of some of debris. Probably.
No problem. You can reduce it.
And at this stage we can give atropine.
0.6 of atropine.
0.6 of atropine.
Because you're holding the wire?
Yes, I'm holding.
Okay.
Now, no, you go now. Go well. Go. Okay. Negative. Okay.
And this
Ask the patient to, okay.
cough.
At this stage, we also ask the patient to cough because
Just
there was
ask her to cough
short.
and give atropine.
No, she's back to the sinus.
Okay, fine.
Now, filter retrieval.
Open the filter retrieval. So normally if you use a tapered stent and if you use a post dilatation not more than 5 millimeter, the chances of bradycardia are very low. And here she just had a transient bradycardia while we were inflating, and it responded. Her heart rate right now is 56. She's in sinus rhythm. And now the next step is to retrieve the filter. Many people would like to aspirate at this stage. Would you like to aspirate?
No.
Okay.
Table, please.
Table down.
Table. Please show me.
Table down. Okay. Just demag.
You had a distal stenosis as well. Do you have any plan about that?
About what?
Which stenosis?
Table, please. Please, table.
In the meningeal angiography,
We go.
No.
Just
That's
remove.
something.
Yeah.
Okay. So we are fine here.
Okay, AP. So it's perfect expansion.
Sister, thoda
And the size is fine also.
Not red. Just 1 second. Okay.
Okay. Okay, we can make AP cranial just for intracranial QCA, the
Now
DSA.
head straight,
Head straight.
absolutely straight, and go a little more cranial.
Okay. Ready?
Just 1 second. Okay.
Okay.
So
Okay.
what we see here is we can see both anterior cerebral, middle cerebral. There doesn't seem to be any cutoff. The patient is fine. Can you ask her to lift her left upper limb? Okay.
Okay.
So she's okay. It's always very important to do a mini neurological examination at the end of the procedure. Sometimes we give them ducky and they keep pressing on the ducky and you can hear the voice. But looks quite fine. If you have any questions, we can answer that.
thank you. I think it was once we done. We worked with bradycardia and then super bradycardia when you balloon.
There was just a transient bradycardia of a few seconds, which is a very normal phenomena. And if you don't post-dilate beyond 5 millimeter, usually it's not a persistent thing.
Yeah. When you were post-dilating, I was looking into. Yeah, but this is one thing that I think we ought to be aware of, that this bradycardia can occur. And sometimes it's a little more than transient at times, so you need to be a little careful
Yeah.
about that. Do you have any point? Yeah, Sashko Kedev here.
Yes.
Looks like a perfect result, straight from the aircraft to the cath lab, I guess, for you. But this is after a long time you have not done a radial approach.
Yes. Yes. So this patient was not originally scheduled for our transmission. With the original patient, we had some technical issues, so we postponed that case. And this patient was with symptomatic carotid disease with acute stroke, subacute actually. And in those situations, sometimes you might need penumbra thrombus aspiration. Also, it can be done radially, but we were somehow in a hurry because we put this patient on a table. It
At
was
1:30. Almost at 1:30.
Yes, at 1:30. So that's why we went femoral. We are a little bit disappointed, but what counts at the end is the patient outcome. So it's very important access site, but at the end is very important final outcome.
Thank you, Sashko.
Thank you.
Khanna.
Thank you.
Wonderful.